Nidhi, shall I start?
Yes, sir.
Okay. Good evening, delegates and participants. Thank you for joining Shield Connect. And today we are back with our famous series, Icons in Conversation with Dr. Ritu. And today we have a special icon from Chhattisgarh, Bhilai, Dr. Sangeeta Sinha. And today's topic, ma'am is going to discuss about his role of GnRH agonist and antagonist in clinical practice. So before I hand over the session to our icon for the day, let me give a brief introduction of Dr. Ritu Santwani, who have sponsored this series with Shield Connect. So let me introduce Dr. Ritu Santwani. Ma'am has done MBBS, MD, FICOG, FIOG, MR, COG, ART Singapore. Ma'am is obstetrician and gynecologist, sexologist, cosmetologist, and infertility specialist. Ma'am is founder and CEO of her new clinic, 360-degree Healthcare Studio. And ma'am is also director of Shamwell Women Clinic and PTBC. Ma'am is also co-founder of MAAM, board member of WSCG. And with this, let me also introduce our icon for the day, Sangeeta Sinha, Dr. Sangeeta Sinha. So, ma'am has done MBBS, DGO, PGA in ART. Ma'am is currently president of Foxy Bhilai AOGB since 2022 till 2025. Ma'am has done PGA in ART from Warwick University, UK. Ma'am is owner, director, and senior laparoscopic and IVF specialist of Srijan IVF Test Tube Baby Center in Bhilai, India. Ma'am is also director of Revival Medical Center in Bhilai. Ma'am is also DGO, obstetric and gynecologist in Patna Medical College in Patna, India. The positions of responsibility of ma'am is the clinical secretary of Indian Medical Association, Durg, India, since 2022 to 2023. Ma'am was past vice president of Foxy Bhilai since 2017 till 2019. Also chapter secretary of IFS Chhattisgarh, India, 2017 to 2019. Ma'am is also secretary of Foxy Bhilai in year 2014 to 2016. And 1 minute. And the education and training related thing is ma'am is a Foxy certified infertility training center, co-convener in master class infertility from IFS, and also ma'am received IMA appreciation award in 2015. So ma'am, we welcome you on our platform for today's session, and I also welcome Dr. Ritu Santwani for making this webinar possible with today's icon, Dr. Sangeeta Sinha. So I hand over the session to you, ma'am. Thank you, ma'am.
Yeah, thank you, Nishant. A very, very warm welcome to the icon of the day, Dr. Sangeeta Sinha, madam. And a very warm welcome to all of my dear friends who have joined all across the geography. I'm so happy to see that some of my friends have joined from Egypt and Saudi countries. So very, very warm welcome to all of you, dear friends. And a big thanks to dear Nishant, Chitra and Sahiti for constantly providing the platform and always be with me, whether it is rain or hot or cold.
Thank you, ma'am.
This series from last year, and series is going very well. So you all are aware, in this series, every Thursday, 8:30 p.m., I am coming with one icon and we are discussing on one important topic. Post that you can have the question answer discussion. So our today's icon is none other than a very prestigious personality from our Foxy, Dr. Sangeeta Sinha, madam. Madam, many, many congratulations to you. Madam has recently taken over as the president of Foxy Bhilai. I know madam from last so many years. We met in some conferences. In the very first visit only, I was very much influenced by the madam's personality and madam's interaction with us. So today, madam is going to discuss with us a very, very important topic, role of GnRH agonist and antagonist in the clinical practice. So friends, as all of those who are doing the ART practice, we all are aware the role of the GnRH is very, very important, especially when we are giving the trigger. At that time also, there is a lot of doubts and confusions in everyone's minds. So let's first listen to the madam, and then we can have some live question answers. So friends, those who have joined from here, yeah, most welcome. And some requests I am getting for the recording of the program. So friends, the program is going live on the YouTube, so you can go through that channel also. A very, very warm welcome to you, Sangeeta Sena madam. I am really honored that you have accepted my invitation and taken out time from your busy schedule. Over to you, ma'am.
First of all, thank you, Dr. Ritu. It's pleasure is both sides. Pleasure is mine totally. And I thanks Mr. Nishant, Saheti and Nagla for inviting me, and Dr. Ritu, you all. So for introducing me to your audience, it's really an honor for me, Dr. Ritu. And actually, the idea behind choosing this topic was that for the last 5, 6 or 7 years, I'm just running a training center. And most of the time when the students come, they're a bit confused about sometimes agonist and antagonist and all these things. So actually this presentation I made for in a simpler way, exactly why we are using this agonist and antagonist in infertility practice. So I'd just like to share my presentation and then start. So is the presentation visible over there?
Yes, ma'am.
Yes, ma'am.
Yes,
Okay.
ma'am.
Okay. Am I audible properly?
Yes,
Yes,
ma'am.
ma'am.
Okay. Okay. Thank you. Thank you. So thanks again, once again, thanks Ritu. And actually today for another 30 or 40 minutes, I am going to deal with agonist and antagonist molecule. So how this molecule is we are using in our IVF practice, and apart from that also in the clinical practice. So basically when we are making a follicle, either for the IUI or for the IVF, what is the ideal target we are going to do? Starting from day 2 till the pickups, either it may be day 11, day 12, day 13. We just want an equal cohort to go, and at the time of pickup, we just want to extract the exact number of follicle we were seeing or with the mature follicle. So this agonist and antagonist, what they say is the right and left. If we are using it in a proper way, the proper time with the proper dose, then it's an ideal stimulation and we are going to extract the good number of follicles. So how we are using it clinically, what clinical are available in the market, I will deal with that. So basically, what is the GnRH? Normally, if we understand the HPU axis, hypothalamic pituitary ovarian axis, normally these all are available in the body. GnRH is secreted from the hypothalamus, then gradually it just go and get attached with the receptors, and there is some MPKs, cascades, and that activates the FSH and LH. So what is the difference between this, the GnRH which is inherent in the body and the GnRH which is available in the market? So this is basically a slight difference. The agonist molecule, which is derived from this native molecule, is slight substitution in sex position. For clinical practice, it hardly matters. It's just a slide to show what is the difference between the natural GnRH and the GnRH agonist, which is available in the market. And actually, if we didn't understand what is the basic mechanism, how it acts, what is the mechanism of action of this GnRH agonist? So two things is very important to understand. There are two modes of action of this GnRH agonist. If we are giving in a continuous or daily dose, continuous administration of GnRH agonist. If we are giving in like that, normally what happens? Just a minute, I'm sorry for that. So if we are giving this GnRH agonist in a continuous daily dose, it's just go and attach to the receptors. Then finally there is a suppression of receptors. Then there is a downregulation of receptors, and then desensitization of receptors. So this mechanism of action is very important to understand. What is the second mode of action of this GnRH agonist? The second mode of action is upregulatory effect. When you are giving a single dose of GnRH agonist, there's an initial flare-up effect. So basically, before using this molecule, it is very important to understand these two mode of action of this agonist. If we are giving in a single dose, it just go and attach to the receptors. There's a flare of hormones, or you can say upregulatory effect. And if we are giving in a daily dose, then it get attached, then there is a downregulation, then there is a suppression and loss of post-receptor mechanism. And so the action, so it suppresses the receptors. So with these two mode of actions, we are going to use this molecule. Either we are using for in the stimulation or we are using for the trigger. And if we are not aware of these two different modes of action, sometimes becomes difficult. Kitna lagaun, kya lagaun, kaise lagaun. So continuous is down regulation and single dose is up regulation. What is the market preparation which is available? Normally we are using leprolide and brucellin, and nasal nafrolin is also been used, and the decapeptyl. But otherwise, gosfrolin, triptolin, they are also available. And study says that there is no difference, either you are giving daily injections or you are giving depot injection or you are giving the nasal spray. There is no basically difference. Most commonly used preparation is the leprolide and brucellin. So how we are going to use these preparations and in which, what is the role? So one important role of this GnRH agonist we are using in ovarian stimulation. What next use? In trigger. Other we are using since decades, endometriosis, fibroid. One latest thing which is not very commonly clinically using, but yes, we are using this GnRH agonist also in luteal phase support. I will be coming one by one in detail. Central precocious puberty, gonadal protection, and prostatic malignancy. So coming to the first one, how we are using this GnRH agonist in ovarian stimulation protocol. Again, repeating the same thing, continuous downregulation, single dose flare-up. So how we are using in ovarian stimulation protocol? Yes, I think it's very common. We are using in long protocol, in short protocol, one-stop protocol, and microdose flare-up protocol. So how in long protocol? Long protocol, we also call it downregulation protocol or flare down protocol. Yes, we are starting these agonists multi-dose from day 21 of the previous cycle till day 1, and then the dose is halved, and parallel we are starting the gonadotropins till the day of trigger. It's very simple, as you can see in this picture. Long protocol starting from day 21, then giving till day 2 and half the dose, and then the day of trigger. I think for decades earlier we were using, nowadays the role of this protocol has slightly decreased. What is the basic molecule we are using? As I told you earlier, leprolide and brucellin, 0.5 to 1 milligram daily, and then the half the dose. Again, if we are not in some patients, or if we are not planning to use this daily dose, we can use depot preparation, especially good for endometriosis, a single dose. Again, if we are not in our scenario, sometimes the patient are not very alert, but we can use nasal spray also, 6 divided dose and then half the dose. So in these 3 ways, in long protocol, we are using this GnRH agonist. Full dose from day 21, then half the dose until the day of trigger. As this slide shows. So exactly how we are going to calculate the dose. किस patient में कितना देना है exactly is very important. A patient of 60 kg or 65 kg or 50 kg, and again the age is also important. So theoretically, if you ask me, the dose is 0.01 ml per kg of body weight. So just to simplify, normally these vials of multi-dose vials come in 4 ml. Some company also comes with 2 ml. So if we are taking 4 ml of vial, and the dose is 0.01 ml per kg. So exactly is 1 ml is equal to 1 milligram. So a patient of 50 kg will need 0.5 ml, or which is equivalent to 0.5 milligram, because the vial contains 4 ml is equal to 4 milligram, but some company has come with 2 ml with 2 milligram. So now for 50 kg patients, we need 0.5 ml, which is equal to 0.5 milligram. And if we take a insulin syringe, which is a 40 unit, so 20 unit. So we can order our sister, if the patient is 50 kg, 20 unit laga do. If it is 55 kg, so it may be 22 unit. So in this way, we can precisely control the dose. But exactly in clinical practice, we have to look for other things also, age and other pieces, how much we need the down regulation. But exactly theoretical, if we ask you, this is the actual dose calculation. So actually, this is a very good protocol, which we are, I think when I started IVF in 2008, this was the protocol we are very commonly using. We were doing batch IVF. So the benefit is very good. It prevents the premature research, and it's go in a mathematical way, decrease cycle cancellations. And yes, follicles grow in a coordinated way, and recovery definitely is good. But nowadays we have shifted from quantity to quality. Numbers less matters. It is the quality of the oocytes that's very important. And if we are getting more number of oocytes, the quality of embryo is decreased, oocytes is decreased. So that's why this protocol is gradually was decreased, and the other protocols came in the fashion. But the most important reason was OHSS. And the most important reason was ovarian hyperstimulation syndrome. And the other side effects, like there is much more down regulation, so hot flashes, dryness. And yes, when we have down regulated, then we need much dose of gonadotropins. So this is the one way where we are using GnRH agonist for the ovarian stimulation. What next? Yes, flare-up protocol. What exactly we do? Actually, it is not very commonly practiced, clinical use, but yes, it is a very good role in poor responders. Here, the agonist is started in full dose. Again, full dose means 0.01 ml per kg body weight. It is started in full dose from day 1 to day 3, as you can see in this slide. Full dose in day 1, day 2, and day 3. Either it is a spontaneous cycle or OC pill cycle, induced cycle. So we have given a full dose of GnRH agonist, and parallel we have started gonadotropins. And here again, what I told in the first slide, mechanism of action, mode of action. Here what we are using in the way of agonist, we are using the upregulation effect. What does GnRH agonist go? It go and attach to the receptors, and there is a surge. So here we are using the inherent FSH LH apart from what we are giving from outside. So especially it is used in poor responders, and there is a flare-up effect. So it is only used for the first, second, and third day, and parallel gonadotropins is being used, and the same way SCG and pickups and transfer. So second role when we are using for stimulation, again for short protocol also we are using in the same way, like we are giving a full dose and then half dose, and finally here there is no premenstrual use of GnRH agonist. GnRH one-stop protocol started from day 21 and full dose, and at day 2 we withhold it. Withhold once and gonadotropin started. Study says that there is no premature LH surge, but definitely this one-stop protocol, this a flare-up protocol, these needs much more study, or when we are getting exhausted with the normal protocols, we can try so that we can squeeze much more things. We didn't have an option than that. So for the ovarian stimulation, we are using agonist as a long protocol, ultra short protocol, one-stop protocol. Now coming to the second role of agonist, which we are using. We are using it a trigger. Now we are using it very commonly. So here we are using the second action, the flare-up effect. And especially we are using an antagonist protocol to be OHSS-free clinic. So in antagonist protocol, we have replaced SCG and we have used GnRH agonist as a trigger as a single dose. So upsurge, upregulatory effect, lots of surge of LH, M1 is converted to M2. Again, the dose, we are using either brusylin or triptolin or lupride. Lupride, again, normally in clinical practice, I am using 0.5, but literature say it can be used between 0.5 to 4 milligram. Again, patient variations, slight descent bits, one can individualize the dose. And the most important advantage, prevention of ovarian hyperstimulation syndrome. Side effect, yes, we all are aware. Luteal phase defect is there. So we have to, if we are planning for the fresh transfer, overload the luteal phase. Lots of progesterone and support is to be needed to be given. So the second role of this GnRH agonist is as a trigger. Yeah, large prospective study has shown that this is very good, especially in the donor patients, the follicle more than 8, more than 10. And so it's better to give the agonist trigger, and it's very commonly used in the oocyte donation programs. So first role was we are using in the stimulation protocol in a different way. Second, we are using the trigger. Now coming to the third use of clinical use of GnRH agonist. Yes, sometimes just a slide before I told you, we didn't give if we are giving GnRH agonist trigger, there is some luteal phase defect. And in this slide, I'm telling you GnRH agonist for supporting the luteal phase defect. Yes, this is some recent study. Actually, I'm also not using it in the clinical practice, but I'm also not using in the clinical practice. Am I audible properly?
Yes, ma'am. Yes.
Okay. Okay. So the third clinical use of this GnRH agonist is in the luteal phase support. So actually, what is the logic behind? Actually, it is in the research phase, or some people are using. GnRH agonist has shown to stimulate the trophoblast production of SCG. There was a study which was published in Journal of Production in 2015, RCT trials. And what the trials show, that if we are using a single dose of GnRH agonist in luteal phase, in a patient, they have a comparative trial, and they have used a single dose of GnRH agonist in luteal phase in the patient which had a previous IVF ICSI failure. And it was given 6 days after ICSI, 0.1 milligram of triptolin or 0.5 milligram of this leuprolide, 6 days after ICSI. And they 6 days after oocyte retrieval, 6 days after ICSI, or you can say oocyte retrieval, with previous history of 2 or more IVF failure. And the study say that they found that there was a significant improvement in implantation and pregnancy rates. So one study I found it with this. One more study which was published in Human Reproduction, beneficial effect of luteal phase GnRH agonist administration on embryo implantation in both agonist and antagonist, treated ovarian stimulation cycle. And they suggested that GnRH agonist has a direct action on embryo and endometrium. They also have given a dose of agonist 6 days after this pickups, or 6 days after ICSI, and they found that there is significant increase in the level of progesterone also, and the outcome was good. There is one more study in this context that was in Middle East Fertility Society Journal, and as a luteal phase support in a randomized controlled trial, single dose 0.6 days after retrieval, but exactly they didn't find any difference in the clinical pregnancy rate. In the chemical pregnancy rate, but clinical pregnancy rate was higher. So actually 3-4 studies are there. We say that in luteal phase, we can give a single dose of GnRH agonist 6 days after pickup, and the results are good. What is the logic behind that? The logic behind that the study says that GnRH receptors is expressed in the human pre-implantation embryo, endometrium, and corpus luteum, implicating a direct effect on GnRH agonist on these targets. Again, as I told you earlier, GnRH agonists have shown to stimulate trophoblast production of SCG. And that's in this way, it improves implantation. Practically, I am not using. I will be happy to if you share me your outcomes if anyone is using. But this is the one clinical use of GnRH agonist. Again, the other fourth use of GnRH agonist we all are using since I think our college days, down regulation, and for the endometriosis, nothing new in that. For fibroid, again, the same pattern, down regulation, suppression, and decrease the blood flow, and same like. Yes, in precocious puberty, also we are using. It holds the puberty as well as the accelerated skeletal growth. Depot preparation is given 7.5, 11.5, 15 milligram every 3 monthly. Only one patient has used, and even though the patient was lost and there was not lots of follow, so we'll happy with your input. Yes, this I find very promising. GnRH for gonadal protection during chemotherapy. Now we all are towards the oncofertility. You need oncofertility. How we are going to save this, because the cancer survivors now come back to us, and what to do. So suppose there is a patients who have some cancer ailments, and that is hormonal dependent, you can say, or they didn't have a time, or the mental makeup. So they didn't have a time for the pickups, for any one-stop protocol or emergency protocol anyway, what we are doing. So they didn't have a time. So in that case, if the agonist is not hampering what the cancer etiology is there, or if, then we can give this gonadal preparation, so that the pre-antral cells antral cells hibernate to pre-antral cells, and there's a decreased perfusion to the ovary and suppression of the HPO axis, so we can conserve some oocytes. It has been seen that there is a high rate of resolution of oocytes and ovulation happens. So this is one of the role we can use. If we didn't have any option, patient can't, we can't freeze the oocytes, or we can't freeze the embryo, then we can go for this option, keeping in touch with this oncologist, tie up with the oncologist. So this was the first molecule I discussed in ovarian stimulation as a trigger in luteal phase support. Yes, for gonadal protection in chemotherapy, apart from fibroid, endometriosis, and precocious puberty. Now coming to the second half of the molecule, second molecule, which I will ask to speak by my dear Ritu, is the antag. Normally we all are antagonist to bolte nahi, antag hi bolte. So we are just so fond of this molecule, antag protocol. So it's also a peptide, and this slight change in this histamine at position 2 is replaced by tryptolene at position 3. Now we all clinician not bother about that. We just need antag, and the antag we are using nowadays are the third generation antag. Commercially, citrulix, granulix, two types of molecules are available. Again, the mode of action is simple, not so complex like this agonist. So they just go and block the receptors, block the GnRH receptors, not like long and down regulation and post receptor, nothing. The action is short, jana hai and block karna hai, and then again they reverse by very rapidly. So the half-life is short. So the immediate but reversible action is there. Immediate and reversible, no receptor loss is there. So we are now, it is actually this, we are using very commonly this molecule. Yes, we all are aware. As I told you in my first, initially first 5 minutes, that we are using this agonist or antagonist. What is the idea? No premature LH surge. So actually for the same molecule, we are using antagonist, preventing the premature LH surge before pickups. Again, second indication, yes, we don't want IY on Sunday, or the husband is not coming, or we are busy in some conference or some webinar or some seminar. So we can use that. In Thaw cycle, sometimes we use to prevent premature LH surge. And yes, in PCOS patient, elevated LH. So we can use this on day 2 and day 3 to decrease our LH. Reversible action, that's the plus point here. Turant gaya and turant the action, and it's reversible. Sometimes we are using this antagonist in the one of the worst situation. Now we are not very commonly facing with that early onset of ovarian hyperstimulation syndrome. And one latest thing I found here, actually I'm not also very using, and I've not seen very commonly, but there was one thing which I found in the literature when I was going through last 15 days back. In poor responders, the baseline FSH is fluctuating widely. And so using, using this premenstrual GnRH antagonist, single dose 3 mg in luteal phase. Look, while we are making a follicle, what is the idea? Equal cohort, equally growing. We don't want 2 mm, 3 mm, 5 mm. On day 2, we just want an equal cohort to go together. So in poor responders, sometimes we feel we should give if it is given GnRH antagonist in the previous cycle, the synchronization of the follicle is there. Because as we all are aware, in these poor responders, they are actually in a high FSH, chronically high FSH. So sometimes on day 2, we can see a follicle of 8 millimeter, 2 millimeter, 3 millimeter, 4 millimeter. This is the only thing we are seeing on day 2. Oh. So if we are giving this, then the early follicle, there is no discordance is there. But actually, clinically, I have not practiced this. I found in the Google. I'm just planning to think in some patients. So coming to one by one, there's nothing much to elaborate here. So for ovarian stimulation protocol to prevent premature LS surge, nothing new. We all are using this fixed protocol and flexible protocol. Starting from day 6, the fixed protocol and flexible protocol is starting when the follicle is 14 millimeter and daily, giving it daily till the trigger. This way. Fixed protocol from day 6 and flexible protocol when the follicle is 14 millimeter. Mostly in 80% of cases, almost it is the same. Secondly, I told you we are using herein, we are using herein. Sometimes it's the PCO patients and we are planning for the stimulation and the LH is very high. And it's like we are going for outside. So how can we plan? So a single dose or 2 doses of antagonist on day 2 and day 3 will just suppress your LH and you can start your stimulation. This is the second use of GnRH antagonist. Thirdly, we are planning for the IY and the husband is reaching on Monday, we are planning on Sunday. So give your antag and then give the trigger. We can think. But yes, luteal support is much more needed. And there's earlier onset of ovarian hyperstimulation syndrome in Thor cycle. And so I think this were all for the how we are using in our clinical practice the agonist and antagonist. And I will be very happy to share your experience so that I could learn something.
Thank you, ma'am. Thank you, ma'am. Thank you so much for such a crystal clear presentation. Lot of doubts have been cleared. Nishan, please check for any questions.
Yes, ma'am. Dear delegates, participants, if you have any questions, you can post your questions in the chat box.
So, Ritu, I think there's no question over. Ritu, do you have any experience of this luteal phase agonist giving in luteal phase? Do you have any? Have you practiced this?
No, ma'am. No.
And what I learned recently, premenstrual antagonist.
Yeah.
Premenstrual, if we are giving antagonist so that the cohort should be equal. Do you have any idea or clinical practice, or are you using that?
Ma'am, no, I'm using. No, not using. That's why I was very much interested for this lecture. So he let me know, because these are some thoughts once we discuss today. Whenever we meet, we can discuss all these things. Yeah.
Achha, Ritu, there was one. How much agonist you are giving in the trigger? What is the dose? Exactly.
Ma'am?
Am I audible? No.
Yes, ma'am. I think
Ritu has become muted herself.
She will rejoin 1 minute now. I think she got disconnected.
Might be. So any questions from the audience, or you can share your experience? We'll be very happy to say.
Dear participants, any questions from your end, you can ask Dr. Sangeeta Sinha. 1 minute, ma'am.
Yeah, let it join. So actually, it is very important to understand the molecule, and these agonists and antagonists, what is feel is the right and left of the stimulation. If we are carrying on this molecule, yeah, Ritu. If we are carrying on this molecule in the proper way, then the outcome is very good. Otherwise, slight hit and bit will lead to lots of, we are sitting for the pickup and we are just finding, oh, the follicles are released.
Sorry, ma'am, I was disconnected in between.
Yeah, Ritu.
Ma'am, your experience, do you using the Cetrolix in your for the IUI cycles also?
No, Dr. Ritu, not actually. I just try to avoid this Cetrolix because, but in the one of the worst circumstances, suppose we are just predicting that we are going for the IUI on Monday, and the follicles and the husband is outside and we just given a dates. नहीं आप husband को इस date में बुला लीजिएगा. Or sometimes the husband is out. Then in those worst circumstances we can do. Otherwise, the better option is freeze the sample. And if the husband is like, he may come, he may not come. But definitely, in once a while, I remember I am using this protocol. This once a while I am using this antagonist.
Ma'am, yesterday I was having one patient.
Yeah.
So patient was telling me, my husband is going. So ma'am, please give me Cetrolix injection. I told her, who told you that we can give the Cetrolix injection? We are planning for IUI this cycle. So she told me, I read in the Google that we can give that injection.
Yes,
So,
they are very...
These days, now.
No, it's actually the theoretical things are very different when we're sitting in
Very
the OPD.
true, very true.
So, but this is one of the indications, but I hardly remember I have used this Cetrolix for the IUI patient. Normally, for the teaching purpose, if you ask, yes, on day 2 for polycystic patient, if the LH is high, yes, we are giving. But this too, I will just say myself, what is the hurry for doing this stimulation? Why don't you wait for another 1 or 2 months and do a probe? Because you may have bad follicles, or you may need much more node of gonadotropies to get the good follicles. So we should be these treats and bits are, yes, they are good. We can use that. But why to can say use an antagonist for IUI cycle or this antac on day 2? Antac is good for the preventing luteal phase support. Yes, they are very good. And freeze all the embryos. That's the best way to use the antac.
Yeah, correct, ma'am. Correct. Nishan, please take over. Nishan.
Yes, ma'am. So, any questions? Dr. Vijay, you have any questions, sir? So, ma'am, I cannot see any more questions or anything from our participants.
I think Dr. Vijay was some...
yeah, Dr. Vijay Chavan. Sir? I think participants
Yeah,
in
there's
the
no
studio.
So it was very nice to
Yeah.
connecting with you, and Dr. Ritu, and all these lively audience. I think your audience are spreading all worldwide, Dr. Ritu. So that's great. And Dr. Ritu, thank you for giving me the opportunity to connect with your audience and all. And thanks, thanks, Mr. Nishant, and thanks, SEAL team, and thanks all the audience who joined here and spared their valuable time over there. So thank you, Ritu. And any comment from your side, or you just want to say something?
Dr. Ritu is facing some technical issue because it is raining.
It's raining over there.
Yeah, even here it is raining in Mumbai. But we are glad to have you on our platform, ma'am, on Shield Connect, and we would like to have one more session with you on some different topic.
My pleasure, Nishant. My pleasure. So thank you all. Thanks. I think
I'm so sorry. I'm so sorry. Sangeeta.
I was just waiting for you to connect, Dr.
I don't
Ritu.
know what is happening today. Again and again, the connection.
Might
was-
be
Maybe
rain
due
and
to this raining.
Yeah. Ma'am, thank you so much for such a nice illustrative presentation. Definitely, we will have one more session along with the madam. Thank you so much.
Thank you,
ma'am.
Dr. Ritu. Thanks all the audience. Thanks a lot.
Okay,
Thank you.
okay.
Bye.
Thank you,
Yeah,
ma'am.
Bye-bye.
thank you,
God bless.
Nishan. Thank you,
Bye.
Nishan. Bye.
Bye.